foot. Most of this we mentioned already. Chris wanted me to talk about the role of an anaesthetist, just in case you weren't sure, let's clarify that. Interfere with sodium channels, ascending and descending pathways. To expect. So spinal anaesthetics, this is diagram enter. We put a spinal needle through between the spinous processes, they're the bony bits in your back, and we go into this area where the CSF is. We inject a smaller volume of local anaesthetic. The spinal cord actually finishes up around L1, and this is the cord equina, which is below there. We don't like sticking a needle in where the spinal cord is in case we cause damage, so we aim to go below that. But the local anaesthetic we inject will move up and down in a certain amount. Just for interest's sake, the difference between an epidural and the spine, we don't use many epidurals these days, apart from in labour ward for analgesia during labour. In the past we have, but an epidural is where we numb the epidural space, which is this space here just behind the spinal cord, and that's usually a catheter technique. So the needle we put in, it doesn't go all the way into the CSF. We stop in this space here and insert a catheter, which we can use as an infusion top up. Just so you know the difference between an epidural and the spinal. This is what I was just talking about before we paused. Complications of spinal anaesthesia, all the way from minor through to major, including the most major. The thing that a lot of us fear, and there's a lot of talk about, a lot of work's being done, is some sort of hematoma either just behind the spinal cord in the epidural space or within the spinal canal. And that's quite relevant, particularly with the use of anticoagulants, which we use a lot for preventing thromboembolic events. So we've essentially, aspirin doesn't bother us, so it's all right if someone's on aspirin. If someone's got a bleeding coagulopathy, obviously we need to know the details of that. The other medications are things like the NOACs, the Eliquis and rivaroxaban. We like patients to be off those for 3 days beforehand, and then in the post-op scenario, which involves the ward, it's usually the Clexane post-op. So we like a 12-hour gap between Clexane and insertion of an epidural or the spinal, if it's for a prophylactic dose, so that's the normal 40 milligrams a day. If someone's on a therapeutic dose, 100 milligrams for whatever medical reason, we like 24 hours between injection of the Clexane and then the spinal anaesthetic. The other side of the coin is after a spinal or an epidural or removal of the epidural catheter, we like 4 to 6 hours before the next dose of Clexane. So I know there's been some confusion and people wait varying amounts of time, but there's good evidence, and most of the colleges and authoritative bodies around the world talk about 4 to 6 hours afterwards. So if someone's had a spinal in theatre, they can have their Clexane 6 hours later, that's fine. There's no issue with that. It's not going to cause any problems with the hematoma. And the problems with the hematoma, what it does is, if the hematoma expands and it's bleeding, we get pressure on the spinal cord, ischemia of the spinal cord, and unless that hematoma is relieved quickly, there can be permanent paralysis. It's one of the sort of scary complications. Any questions on that?
I will ask a question. There's been a lot of confusion with specifically morphine spinals and
yep.
The minimum time between insertion of the spinal and Clexane being given. So the fact that it's morphine or bupivacaine doesn't affect it.
Doesn't matter, it's the technique,
yeah,
which is the issue. It's
yeah.
potentially causing any bleeding. Doesn't matter what drug it is.
So on an orthopaedic ward, should we be waiting at 12 or 4 to 6 hours is okay?
After a spinal?
Yeah.
6 hours is fine.
Good. Thank you.
And that's the American bodies, the Australian bodies, the English bodies, everyone says that.
Great.
So it's 4 to 6 hours. So that's for a prophylactic dose after a spinal, And it doesn't matter what the drug is, because it's the spinal itself.
Yeah.
And so before, the other option is beforehand, it's 12 hours before the spinal. Again, it doesn't matter what you do, what you put in it, but the actual technique of having a spinal, because we're worried about the hematoma, and that's from the trauma.
Thank you.
That's right,
Working
exactly.
through all the setting.
I know. And there's been a lot of confusion, there's been some delays from the time of discharge, of recovery and all that sort of thing, but it's from the time of the spinal, which is usually recorded on the anaesthetic chart, so you can roughly look at the time the anaesthetic chart started. And as I said, it's 4 to 6 hours, but I think it's probably better to say 6 hours if there's any ambiguity, and just to be on the safe side. But you certainly don't have to wait 12 hours. And there was that confusion between the before and the after, whether the dose is given before the spinal or after the spinal.
And is there any contraindications with having a spinal besides like spinal anatomy?
Yep, absolutely. So we talk about contraindications as usually being absolute or relative.
Yep.
So the absolute contraindications are patient refusal. And we see that not uncommonly. Patient says, look, I've heard bad stories, I've got a bad back, I don't want to have the spinal, and that's fine. We can't impose anything on patients. If they say no, that's fine. It's important they get educated. Often they've got some misconceived ideas about what the problems is or what a spinal is. A coagulopathy, so someone who's got a bleeding disorder, or someone who's had clexane recently, so we can't do a spinal with that. Someone who is has got hemodynamic instability, so someone who's bleeding, for example, we don't want to do a spinal, vasodilate them, which is one of the responses. If you're bleeding, your body vasoconstricts to try and put all the blood to your liver and your heart and your brain and all the important organs. So we don't like doing a spinal on someone who's hemodynamically unstable. And probably local sepsis around where you're going in. You don't want to be putting pus or infection or bugs into the CSF, because it goes in there, up to the brain, meningitis, everyone's unhappy. And the relative contraindications are things like, that's not one of my slides. Spinal anatomy, like you said, maybe sepsis somewhere else if they've got an infective focus somewhere else, but there's only a few absolute contraindications. And if someone's had spinal surgery, it's not necessarily a contraindication to having a spinal, it just depends what the surgery was. Anything else? And yeah, so the morphine, if we're using that, it's always used as well as a local anaesthetic, and that's for pain relief as well, just to give extended pain relief. So beyond when the local anaesthetic wears off, the patient still gets some pain relief. You okay if I move on to peripheral nerve blocks, or is there something else with spinals? So peripheral nerve blocks basically anywhere, and in orthopedics we're talking about arms and legs, basically, just to keep it fairly straightforward. And it's the same principle. The anaesthetic blocks the nerve transmission, and usually we're looking at a single shot, which is we do just a single block in theatre, we'll put the needle in, put in the anaesthetic, take the needle out, that's it. Or we can use a catheter technique, which we put in a catheter, and that can either be hooked up to an infusion or intermittent boluses. And usually it's not the be all or end all, so we usually combine it with multimodal analgesics, so we get anti-inflammatories and paracetamol and physical techniques as well for pain relief.
Oh no.
I know, it's a dad joke. So the reasons we do peripheral nerve blocks, and particularly in orthopedics, it's probably the one subspecialty where we use more nerve blocks than any other subspecialty. Obviously there's the humanistic side of it, just so patients are more comfortable. We don't want patients in pain, so we want better patient satisfaction, and they're more comfortable. We can get them up and moving usually early because they're not lying in bed and they're not in pain. And it also can reduce the side effects. I mean, it's a bit of a shotgun approach, but the best analgesics we've still got and we're working on still are probably opiates, and they come with a whole range of side effects. So patients are sick, patients are drowsy, patients are constipated. And if we can use less of the opiates by using peripheral nerve blocks, then again, we get the patients up and moving earlier, we avoid some of those problems. The sort of complications with peripheral nerve blocks, obviously, sometimes we don't block the nerve that we want. That's less likely these days because we use ultrasound for nearly all our nerve blocks. In the past, it was just going off surface anatomy or paresthesia, but now we use an ultrasound, we visualise the nerve, we visualise the local anaesthetic going around the nerve. There can be complications of the actual technique, and that's irrespective of the local anaesthetic, and I mentioned two there, and they're really with upper limb blocks. So with the interscaling or supraclavicular block, which we do in the neck, the top of the lung is quite close, so it's not unheard of that we can actually cram the lung with a needle and cause a pneumothorax. Again, it's less likely these days because we're using ultrasound, we can actually see where the needle is, but it can still happen. And the phrenic nerve palsy I mentioned, with the interscalene blocks which we use for shoulder surgery, the phrenic nerve is right next door to it. So almost every patient who gets an interscalene block for shoulder surgery will have some degree of phrenic nerve palsy. So the phrenic nerve supplies the diaphragm, and you get an ipsilateral. On that side, we get a paralysed diaphragm. So that's important, obviously, with patients who have got respiratory compromise, because when they take a breath in, the side that's not numb will breathe, but the other side won't move at all. And from a patient's point of view, they often find that quite distressing. They feel like they want to take a breath, but they're actually aware that their diaphragm's not moving. So it's just important to be aware of that. It wears off when the block wears off, but the patients often need quite a lot of reassurance and support to say, look, we know you feel like that. It's because of the nerve block, but it will go away. We can have allergic reactions to anything, motor weakness and falls. Obviously, if we block the motor nerves, then particularly in lower limb blocks, then you have to be careful of patients mobilising. Obviously, bleeding, nerve damage, we can damage the nerve if we're not careful. Secondary injury I mentioned, because if, for example, you've got a numb arm or a numb leg, it's not that hard for the patient to either burn or injure themselves and not realise it. So normally when we're awake and moving around, if we hang ourselves, we pull our hand away and we know. But if your arm's numb, you won't necessarily have that defence mechanism. And the surgeon's always worried about compartment syndrome, particularly with lower leg blocks and lower leg surgery, in particular in the calf. There is a concern that if the patient's got a numb leg, they won't say, look, my leg's sore, and we look at it and they might have a compartment syndrome. Having said that, pain is only one symptom and sign of a compartment syndrome, so there still will be evidence of circuitry insufficiency and have a cold leg and loose pulses and things like that. So it's just balancing the pain relief as against what sort of complications you're looking for. And it's important to have a conversation between the anaesthetist, the surgeon and nursing staff on the risk of compartment syndrome, whether it's likely or not. And then local anaesthetic toxicity, which I'll come to in a minute as well. Some upper extremity blocks, interscalene for shoulder surgery. I've got a table in a minute which will actually go through this a bit clearer. Supraclavicular, that's just above the clavicle, and then further down the arm with specific nerves. As a general principle, what we want to do is do whatever nerve block we're doing as distal as we can. For example, if someone's having a wrist operation, we may not necessarily need to numb the whole arm or give pain relief for the whole arm. As a general principle, it's safer just to provide a nerve block as distal as we can. Having said that, for operations, orthopaedic surgeons will usually use a tourniquet, so we often need to numb that area as well if the patient's awake. So that's the clavicle up here, obviously. The supraclavicular and interscalene blocks are up here, auxiliaries in the armpit, and then we can block specific nerves around the elbow or the wrist if need be. And the lower extremity, the common blocks, nerve blocks we do are those. That's the
obviously the front of the leg. The femoral nerve is the big nerve coming down the front, and it covers sort of the anterior thigh and the knee and the medial part of the calf, and then the sciatic nerve does most of the back of the leg and the foot and ankle. So it depends on what the operation is or what the trauma is that we want to determines where we do the local anaesthetic block. And we can numb essentially any of these nerves at anywhere in their path, depending on what the clinical need is. With the femoral nerve, which in the past we commonly use that for most knee and thigh surgery, but you do get quite a profound quadriceps weakness with that because it does supply all the motor nerves for the quads, and so it's difficult to get patients to mobilise. With the advent of ultrasound, we can actually do an adductor canal block, which essentially is the saphenous nerve block further down in the thigh, and that avoids anaesthetising the motor nerves that go to the quads. So usually it's just a sensory nerve, so we can actually still get a similar sort of distribution of analgesia or anaesthesia, but without the motor component of it. So that's useful for patients to get up and get going. This table is a little bit complicated, but essentially it shows in the upper arm or upper extremity, lower extremity, which blocks, what the indications are, and potential complications of those. And as I was just talking about the adductor canal, it says it's less quads weakness than the femoral nerve block. The pneumothorax, respiratory compromise. Again, Chris has got all these on his emails if you want to get a copy of it from him, that's useful. Last is local anaesthetic systemic toxicity, which is a problem with all nerve blocks, and I'll touch on that briefly in a minute. Any questions? Any comments? Anyone awake? I won't spend much time on this because it's not something you'll see on the ward usually, apart from if you're giving an infusion or intermittent bolus. But essentially it's when patients get systemic local anaesthetic overdose. So most likely it'll be in theatres where we're using large volumes of local anaesthetic, like doing the blocks or doing infiltration for it. It's an interesting topic, and it's again a topic all of itself. So patients do get a few symptoms early on. They often describe a funny taste and ringing in their ears, and it usually, if they get significant local anaesthetic toxicity, it progresses pretty quickly to convulsions and cardiovascular collapse. And you might have seen there was a bit of a flurry a few years ago with cosmetic clinics where patients were having significant operations, breast augmentations and things with local anaesthetic, and they used large volumes of local anaesthetic, and there was a series of cardiac arrests from local anaesthetic toxicity. The patients were having general anaesthetic, having sedation and local. So same thing, get a program, and it can be quite quickly. It's an intravenous injection, and it moves through these stages very quickly, intravascular I should say. Don't worry about this slide. The only thing on this, it's what to do with local anaesthetic toxicity, but I just want to make the point that we treat it with intralipid local anaesthetic toxicity. So it's the same intralipid that's used in TPN. And these patients often need repeat doses, infusions of intralipid, and prolonged resuscitation, depending on the local anaesthetic. There are reports of people with bupivacaine local anaesthetic toxicity getting CPR on and off for like 20 hours. Because bupivacaine is a long-acting local anaesthetic, and what it does is the same way we use it for good by numbing nerve, it attaches to the nerves in the heart, and because it's such a long-acting anaesthetic, you get prolonged anaesthesia of the conduction system in the heart, and these patients need prolonged CPR.
So does that, when that happens, just out of interest, do they just go into cardiac arrest every so often, or?
Yeah, so you resuscitate them, will come good, and then resuscitate them again.
Yeah, wow.
Yeah, so it just goes on and on. And you've basically got to wait for the local anaesthetic to detach from the nerves in the heart. And intralipid, again, it's it's quite interesting, but it's never been studied, but some people have tried it, and it's now the world standard because it seems to work, but you can't study it, you can't make people arrest and
Yeah,
give them
yeah.
to leave. But it's thought just basically to mop up
Yeah.
any remaining local anaesthetic in the circulation.
Interesting.
I've just put this up as a resource. This is the New York Society of Regional Anaesthesia. They've got a website and it's got everything you could ever want to know about regional anaesthesia, the spinal nerve blocks, complications, indications, future research. It's got everything on it, so it's quite an easy website to navigate. But if you're interested or further learning, I recommend having a squeeze at that. So thank you for listening and thank you for looking after our patients.
Thank you.